yote kama mjumbe hapo merudi nyumbani.
The success in the fight against the coronavirus pandemic lies in testing of as many people as possible in order to identify those that are positive, isolate them, then trace their contacts. But what does this testing involve? KTN News medical correspondent Dr. Korir did go through this process earlier on today to bring you this personal account of testing for a disease whose outcome is steeped with stigma.
Today I'm going to have the coronavirus testing done to find out whether I am one of the many Kenyans, of the many people who are asymptomatic or who have mild symptoms when they develop the coronavirus. So as you can see, I have my suitcase ready. This is because after discussions with Dr. Ahmed Kalebi of the Lancet Pathologist Laboratories, he said should the test come out positive, then there's no turning back. I have to go to an isolation facility. This is just to see what the experience is like getting tested and being sent to an isolation facility. It is an uncertain moment. It is definitely scary because I do not know what the consequences will be like, but there's only one way to find out, and that is to get tested, and I shall let you know. It was a scary decision to make, knowing the likely consequences. Other people's experiences in quarantine and isolation have not been exactly encouraging for anyone willing to get tested. My crew and I went to pathologist Lancet for the test early Sunday morning. Not want to find me in a situation where I'm wondering. While filling in this form requesting necessary information, Dr. Ahmed Kalebi explained to me what to expect.
The swab is supposed to go on the floor of your nose, to the back of your nose, because that's where you have the highest yield if there is a virus. Some people can sneeze or feel uncomfortable, but overall it's much more comfortable than even the throat swab. On the other end, Daniel Okech, the head of Home Samples Collection, was getting ready to come and collect the samples. Down. After that, samples are carried in a cooler box directly into the main lab for processing. The samples are processed in the biosafety cabinet, and it will be 3 hours before myself and David Otieno, one of the camera persons for the day, would know whether we need to go for isolation or continue with our day-to-day activities. What we've noticed in the last 3 days, there's been a steep decline from the referrals and also self-requests. The uncertainty around home-based care has a number of Kenyans, including healthcare workers, unwilling to get tested for fear of their families being rounded up and being subjected to mandatory quarantine, whose duration can be uncertain. And those people will not test and they don't know who else they have infected. So I think it's something that probably people have to be educated about, that having a positive result does not necessarily mean that you'll go for what people are calling detention. And there are options for home-based isolation. The ministry has reported that so far 13,000 tests have been done, although it is unclear how many people have been tested. The number of retests are probably less than 5% of the total number. So I'll say in terms of unique individuals tested, we have at least 1,100 tested. Yeah. On Sunday, though, 2 lab tests that will be reported to the Ministry of Health are those of myself and my camera person, both of which are negative. But this does not mean we are immune to the virus. We still have to observe all set out precautionary measures. Dr. Korir, KTN News.
Let's speak to Dr. Korir now, joining us from the studio, from the newsroom rather. Good evening. Quite a bold move there to do this on camera. What was your experience like, Dr. Korir?
Well, as you can see, it was a bit uncomfortable, a bit unnerving, but at the end of the day, we needed to actually show how this test is done and what to expect once the test is done. And as you can see, I was actually ready. In case it was a positive result, then I was actually ready to go to isolation in whichever government-mandated facility, just to follow the government measures from start to finish. But luckily, because I'm here, definitely that test result was negative. So it was an experience and a half, for lack of a better term. I think the thing about it was just that the collection of the sample from up from the nose was uncomfortable, not painful,
it looked
but a bit uncomfortable and irritating. As Dr. Kalebi had said, some people get to sneeze, and when they're taking from the throat, some people get a gag reflex and may vomit, but luckily for us, you could see we handled it quite well. So the tearing was because of reflex of the irritation behind there, but not because it was painful. No, it's not painful, and I think any Kenyan that can get tested should actually get tested so that we know what we are talking about when we are looking at the number of people that have been affected by the coronavirus, Akisa.
But we're still seeing a lot of people still shying away from taking this test. Talk to us about that. What did you find out about why we are not, volunteering to test as much as we can?
I think it's because of the consequences, where you find that once you test positive, for example, then you have to proceed to isolation. And I don't think the going to isolation in itself is a problem, but the consequences that come to your immediate contacts and family members, where now the government comes with police, with medics, the public health officers, and a battery of other people, and they round up families and they want to put them in mandatory quarantine or in quarantine facilities as they await to test. So this sort of has given the whole issue of testing for the coronavirus sort of like a criminal element, where it's almost like a criminal offense to be diagnosed or to be a contact of somebody who has been diagnosed of the coronavirus because of now the consequences that come in. So I think the approach should change, where we see the public health officers probably, or the community health workers coming in to, to trace contacts and talk to people about why they're being traced and take them through, as opposed to, one in the middle of the night, the officers coming for you and you're rounded up and you don't know where you're going and you don't know your fate in wherever it is that you're going. And secondly, I think even from the government data, the people who have been confirmed to have the coronavirus are otherwise healthy, a good number of them otherwise healthy, with mild symptoms or moderate symptoms. Some do not have any symptoms at all. So the question for many is, if I go into isolation when I'm otherwise healthy and I'm incurring bills, is it worth it? So when people think about that, then they're like, if I'm not suffering any pain, if I'm not having any symptoms, if I'm not in any immediate danger, then what is the point of getting tested only to have my life disrupted? So these are some of the issues that I think we need to address around the testing of the coronavirus, not the testing itself as such, because it's an uncomfortable, let's say, 10, 15-second procedure. But after that, the consequences that would befall people is what really needs to be addressed. Otherwise, every measure that we're doing will be defeatist if we are not able to test as many people as possible so that we can establish the true extent of the pandemic in the country.
We are increasingly hearing about home isolation. We've heard it in the interview you had there with Dr. Kaledi. Is this something we now need to consider, even as we're talking about mandatory quarantine and Kenyans incurring extra costs for this?
Okay, Akisa, come again. I didn't quite hear.
On home isolation, I hope you can get me clearly now. We are increasingly hearing about home isolation. We've heard you speak about it with Dr. Kaledi there when at Lancet. Is this something we now need to consider, given that we're continuing to have a conversation on mandatory quarantine? Kenyans complaining about, incurring expenses while at it. So have we gotten to a point where we then need to start considering home isolation?
In my opinion, I think the issue of home isolation or home-based care should have been something that was on the table from the outset, because as we have seen from the global north and countries that have been able to manage the coronavirus so far, the pandemic so far, is that 80% of people will present either with mild symptoms or with no symptoms at all. Then the question that countries are grappling with is that do we admit these people in hospital and have them occupy bed space that could otherwise be of use to people who are otherwise either critically ill or severely ill. So I think for me as a country, we should have already looked at the issue of home-based care. We've seen the bills from some of the people who are in some of these facilities in isolation, and what they're being charged for is just the bed space. If you're going to charge somebody, for example, for bed space, isn't it then better to consider having them in isolation while at home, in a home environment where at least they're surrounded by people they know? So for their mental health, at the end of the day, it's better. And even for healing or getting well, it is even better for them. Now, the thing about home-based care here is that there should be guidelines and protocols to follow that somebody should adhere to while they're at home. If it means logging in temperature every so often, then they can do that and submit that to the public health officer assigned either to the area where they are or a community health worker in the area where they are. There should be sociologists who would assess the suitability of the various homes to see if somebody has the capability of staying in isolation while at home. An example is if somebody is staying, let's say, in a 4-bedroom house where they're all self-contained, then for such a person, it is easy to have a room where they can stay on their own in isolation and have one particular person from the household attending to them. And then they should have testing guidelines that after a certain number of days, we will test for the coronavirus until the day when they turn negative. This way, we will be able to free bed space for the people who need this particular bed space. And remember also, Akisa, is that we have the coronavirus here with us, but the other diseases have not gone away. We are still grappling with malaria, which costs lives. We are still tackling cancer. We are still tackling other pneumonias. Children are still getting diarrhea. So we need to look at this holistically and see what our urgent needs. What can we do in the facility? We do in the facility. What we are able to manage at home, then this would be the time to actually do that because our numbers are still few. So even if it's a matter of piloting a few people who are able to isolate at home and see how to work out the logistics and the guidelines and the protocols and the implementation of it, then this would be the ideal time to actually do that before the numbers increase, as has been projected by some of the epidemiologists that, you know, our numbers could hit the thousands and thousands. So this would be the right time to actually consider home-based care and actually not just consider it, but implement it for many people who would either be asymptomatic with no symptoms or who will have mild symptoms, so that at least we know how we can handle that as a country. Akisa.
How has this worked elsewhere? Because right now we are grappling with the issue of indiscipline among Kenyans, and I like that you mentioned perhaps we could start with a pilot. But any case studies, how has this worked elsewhere where health systems have been strained, hence they had to consider home-based care?
I know in other systems what's happening is that they have the emergency call center numbers, and here we have the 719 number, where somebody who suspects that they may be having symptoms of COVID or they may have come in contact with somebody with COVID, call into the call center. And then from the call center, they get instructions where the call centers are manned by people who are either medical professionals or have some training in the medical field. So these particular people will assess you depending on the symptoms that you're reporting or the complaints that you have. So they'll make that assessment and be able to advise you. For example, if you are asymptomatic and you think you've come in contact with somebody who's tested positive for the coronavirus, then and you do not have any symptoms, then you will be told to stay at home for 14 days, in which time you're told to watch out for the symptoms of fever, of a cough, or difficulty in breathing. And then if you develop any of those symptoms, then you're supposed to call back to the call center so that they are able to guide you on what to do next. If somebody has a fever and a mild cough, for example, then you are also advised to stay home and watch if your symptoms will develop further or if your symptoms will get any better. Now, for somebody who has difficulty in breathing, because it means now the situation is a bit dire, it could get bad sooner, then you're advised to either go to your nearest health facility or they send help to you, where they'll send a crew, trained medical professionals in an ambulance to come and assess you. And if your situation is bad, then they can evacuate you to a hospital. So most of these people are managing people that can be managed while at home, but those who now need in a hospital facility do go to a hospital facility. Of note here is that the people who fall in what we call the vulnerable groups, these are people who are elderly or people who have pre-existing medical conditions like cancer, diabetes, hypertension. These are people who then, if they suspect to have come in contact with somebody who has been diagnosed with the coronavirus or have symptoms, then these are people who are immediately attended to, because we know that they are likely to suffer critical illness from the coronavirus. They're likely to suffer severe disease that may need more critical care, more specialized and critical care. So there's that categorization. So the call centers really come in handy in being able to sift and know who to manage where.
Well, thank you very much for your thoughts there, Dr. Mercy Korir, our medical correspondent, joining us from the newsroom. We'll be taking a short break, but when we get back, we'll be having a quick conversation with Professor Matilu Mwao. He's an infectious diseases specialist as well as Deputy Director, KEMRI. He will be giving us the status of testing in the country now. Remember, Kenya has tested has done over 13,000 tests so far, so we'll be getting more details from